I'm presenting the anatomy of clefts and velopharyngeal apparatus. I am Dr. Olawale Adamson from Lagos University Teaching Hospital, Luz, Nigeria. And before I commence, I would like to appreciate the Smile Train for giving me this opportunity to share this, and also the Lutz Orofacial Cleft team, which is chaired by Professor Ogunlewe and my speech therapy team also. How I'll be using this outline: introduction, a brief problems with cleft lip and palate, the anatomy of cleft lip, anatomy of the palate, the types of cleft palate, velopharyngeal dysfunction, the anatomy of the velopharyngeal apparatus, and conclusion. The aim of this teaching is for us to understand the anatomy and physiology of clefts and the parts that form the clefts, and also to be able to identify the problems that may arise from anatomical deficiencies, and also to provide solutions and to advise the surgeons during management. Like the cheeks, but the commonest one is the one that affects the upper lip and the palate, and it is the most common craniofacial anomaly that we Okay, sorry about that. The problems of cleft lip and palate, number one is feeding. Because the palate serves as a separation between the nose and the mouth. So feeding is important. When there's a cleft lip, cleft palate, most especially, the food passes from the mouth into the nose, making feeding difficult. And also speech difficulty, because the mouth, it serves like a cavity, such that when you are speaking, it separates words that are meant to come out from the mouth, from the nose. So once there's a cleft palate, patient has speech difficulty, and this may also arise with patients with cleft lip because some sounds are pronounced with the lips. We can also have infections, the upper respiratory tract infection and middle infection, and psychosocial problems, that's aesthetics. And because of the look of the children, most parents don't take their children out. It would be recorded that some parents even don't feed the baby because of the social impairment of that cleft. And lastly, there's dental malocclusion, which is common with the cleft palate. So the anatomy of the lip. The normal lip has some distinct features which are consistent. There's symmetry of both sides of the face. That means the right side and the left side are always the same for everybody. And also the lips, they have muscles in them. That's the orbicularis oris that serves as a sphincter to the oral cavity. That means it serves to enclose everything in the oral cavity. And this muscle has blood vessels and nerves that controls the muscles. Also, upper lip has a midline feature. If you see the upper lip, I'll still show you a picture of it. There's a midline feature, and also has a left and right maxillary parts, which indicates the embryological origin. But the lower lip is one continuous structure, and there's no clear demarcation of midline for the lower lip. It's difficult to get where the midline starts from for the lower lip. So each lip has a skin surface and a mucosal part that lines the mouth. The demarcation between the skin and the mucosal surface is called the vermilion border, or the white road, which is more pronounced in the upper lip. For cleft patients, when you talk of reconstruction of the cleft patients, This vermiculum border is important for you to reconstruct it back to normal. So the function of the lip. The lip functions for three major things. For speech, like I said earlier on, some sounds are labial sounds. They are generated with the lip, like the pa, the ba, the f, and the v. Those sounds use the lips for pronunciation. So patients with bilateral cleft lip may have difficulty using those sounds. Even though many of them overcome it, but some of them can have problem pronouncing those specific sounds. And the lip also creates an oral seal, which is important during eating and drinking water from straw, because the lip sees the oral cavity and shows that you can suck in fluids from a straw. The vacuum for swallowing. And lastly, aesthetics. One of the main features that people look at in the person's face is the lip. Is the lip. So it's the major aesthetic unit of the face. And proper alignment of the lip leads to improved social confidence. Now go to the anatomy of the lip. You can see my screen, and I show different parts of the lip, the tip of the nose, the philtrum, lip. You can see from my screen the major part of the anatomy of the lip. Like I can see the philtrum, which is this whole segment of the lip. There's the philtral column here, and this is the cupid's bow. And this whole line on this point is the white row, which I said is important for it to be continuous for the lip. And for cleft patients, it occurs when there is a separation of one philtral column from this other part, the maxillary part of the lip. So the types of cleft lip that we have, it can be incomplete, can be unilateral or bilateral. It can be complete, which can also be unilateral or bilateral, and microform cleft. In microform cleft, the skin is intact, but the muscles have clefts. So even though the lip may look a bit normal, but you see like a depression in the skin, which shows that the muscle is deficient. And this is a picture of a patient with an incomplete right lateral cleft lip. It's incomplete because you can see the nostrils on both sides equal, means that the cleft doesn't get to the nostril. And you can see what I said here, this is the white row for this baby. And you can see there's a breach in the white row here. And the whole philtral segment is on one side. So this is a right incomplete unilateral cleft lip. Next, here, you can see is a left complete unilateral cleft lip. You can see the nose of this baby is widened compared to the first one. And one here is a bilateral cleft lip. There's cleft on both right and on the left side. You can see with this baby, it's difficult to create an oral seal. So production of some sound like the pa, the ba, and the v may be difficult. So the anatomy of the palate. The palate is an important structure of production of oral sounds. It serves as a barrier separating the oral and nasal cavity, and thus it prevents leakage of sounds to the nose. It also serves as a site for speech production of certain sounds like the ka and the ga, which are produced in the velum. The palate has two main parts. the hard and the soft palate. The hard palate is the bony part, and the anterior part, that's the front, that has the nerves and also has the mucosa. Then the soft palate is the muscular part that makes up the velopharyngeal apparatus. And this is a diagram of the hard palate. It has two parts. It has two parts. The maxillary part and the palatine part. And you can see from here, the holes. This front part is called the premaxilla, which serves for attachment of the incisors teeth. These 4 teeth here are the incisors. So this premaxilla serves as attachment for the incisor teeth. And we have these holes here for the nasopalatal nerve, and this for the greater palatal nerve and lesser palatal nerve. So they have the holes for the nerves that supply the palate that come out from there. So this is the oral part of this palate. Above this is the nasal part. And you can see a clinical picture here that shows, you can see the hard palate. There is a change in color from this hard palate to this soft palate over here. This is the hard palate, and this is soft palate. And types of clefts of palate. Actually, the cleft of soft palate, the cleft of the hard of soft palate, which can be lateral or bilateral, and the submucous cleft. So for the lateral cleft of the for the hard palate, left of hard and soft palate, you see a midline cleft in the palate that goes from, this is the picture of first, a cleft of the uvula. It's right at the base of the end of the soft palate. And this shows the cleft of the soft palate alone. You can see in front here, the hard palate, and where the soft palate starts from, there's a cleft here. This is the cleft of the soft palate. And over here is a cleft of the hard and soft palate. So a submucous cleft. And this is like a cleft of the soft palate, but is not very obvious to the naked untrained eye, in the sense that the mucosa is still intact, but the muscles that make up the soft palate are separated. There's a cleft there. And it has 4 characteristics. 1, a bifid uvula. 2, a zona pellucida, and that's a bluish line at the middle of the soft palate. And lastly, there's a junction, a notch at the junction of the hard and soft palate. And the last one is hypernasality, in production of high pressure sound. Most times, even some patients, they come when they are old, and their major complaint is that their mouth is normal, but their sounds are hypernasal, and they are worried. But actually, they have this submucous cleft. And because the untrained eye has seen the mucosa as normal, they can't identify the cleft of the soft palate, of the submucous cleft. The zona pellucida is a bluish area in the middle of the velum, and it's caused by the thin mucosa. And because that's a lack of normal underlying muscle there. And this is a picture of a submucous cleft. You can see here a thin bluish line at the middle here. Beside the line is pink, showing there's a muscle on either side, and this bluish line here is the zona pellucida. And for this, you can see the bifid uvula over here. So this patient has a submucous cleft. To the untrained eye, this looks normal, but this patient represents hypernasality. And this is a submucous cleft that needs to be repaired. The velopharyngeal mechanism apparatus or dysfunction. The velopharyngeal mechanism is comprised of a complex group of structures that act in unison to control the airflow through the nose and mouth. And that's by elevation of the soft palate and constriction of both lateral and posterior pharyngeal walls. Velopharyngeal dysfunction is a generic term that describes a set of disorders that result in the leakage of air to the nasal passages during speech production. Normally, when you are making sound in speech, there is a block, a separation from the nasal cavity, from the oral cavity, such that the speech that is made is limited only to the oral cavity. But whenever there is a leak of air from the oral cavity to the nasal cavity, it's termed a velopharyngeal dysfunction. And this can result in hypernasality, nasal emission, and poor intelligibility of speech. And velopharyngeal dysfunction, that's VPD, it can present as, like I said, hypernasality or facial grimacing. So velopharyngeal dysfunction is a general term, and there are three parts of it. There is velopharyngeal insufficiency, which is due to the abnormal structure. There is velopharyngeal incompetence, which is due to abnormal movements. And there's velopharyngeal mislearning, which is due to abnormal speech sound production. For velopharyngeal insufficiency, it is due to the muscular defect in the velopharyngeal mechanism. It can be like in cleft palate patients, or even after repair, when the muscles are not properly aligned together or the muscles are not properly moving together, functionally repaired together, they can be velopharyngeal insufficiency. But incompetence, the muscles are normal, but there is incompetence due to maybe the nerve deficiency, can occur in cerebral palsy, or when the patient has a stroke, or when the patient has a nerve defect like aphasia or a myasthenia gravis. In this, the muscle, the whole structure looks normal, but the nerve that supplies the muscle is abnormal. So the patient has a velopharyngeal incompetence, and there's velopharyngeal mislearning. That's when the patient has an abnormal speech sound production. It's important to separate these three because their management is different. Because for some, like for velopharyngeal incompetence, a proper speech therapy and muscular training will suffice to help. While for velopharyngeal insufficiency due to cleft lip, the patient needs speech therapy but does not need a muscular training. So the anatomy of the velopharyngeal apparatus made up of two parts, the velum and also the pharyngeal walls. The velum is the soft palate, and the muscles that make up the velum are the levator palatini, the tensor palatini, palatopharyngeus, and lastly, the musculus uvulae. And the pharyngeal wall is made up of two muscles. It's made up of the lateral pharyngeal wall and the posterior pharyngeal wall. And they are both made up of the superior pharyngeal constrictor muscle. The tensor palatini is attached to the posterior wall of the palate and also to the eustachian tube. It drains the eustachian tube. When this muscle is defective in cleft patients, it leads to middle ear infection. And the levator palatini is the major muscle that moves or elevates the soft palate. It is the major muscle that needs to be restored for speech. It is attached to the pterygoid amylus. I'll still show you all this. And the palatopharyngeus muscle depresses the soft palate and the musculus uvulae. And this is a picture here showing the muscles that make up the soft palate. We can see that the levator palatini is from the amylus here, and it goes downwards to the soft palate. The opposite comes here, it forms like a V. And when it contracts, it lifts up this soft palate. And over here is the tensor beneath the levator. The levator has been cut to show the tensor that attaches to the palate posteriorly, forming the aponeurosis. And over here, the palatopharyngeus, and this when it contracts, it pulls down the soft palate. And lastly, this one here is the musculus uvulae. And this is showing the side view of what I just showed earlier. This is the soft palate that you see. And over here, you can see this muscle going upward this way. Is the levator palatini. It's when it contracts, it pulls up this soft palate. Here is the tensor, also pulls it up, but minimally. And here is the palatopharyngeus. It depresses the soft palate. So these muscles work to pull up the soft palate, and this is the constrictor muscle, the pharyngeal wall. So it pulls up this muscle to meet up this pharyngeal wall, therefore creating a separation between this oral cavity and this nasal cavity. And this is also a schematic diagram showing what I just described earlier. This is the velum. When it contracts, it pulls it up to this pharyngeal wall, separating this oral cavity from this nasal cavity, so that sounds that are produced in combined with the glottis comes out in the mouth. So when there's a pharyngeal insufficiency, this mechanism is effective such that air escapes from the mouth into the nasal cavity. I'll still show you that later, which is here, which is what we see here. This is a normal speech. When you're making your speech, this is the soft palate. It completely occludes with the pharynx, the pharyngeal wall, so that air that is coming out, you can see, it comes out only in the oral cavity. But this second one is a patient with VPI, velopharyngeal insufficiency or incompetence. There's a separation between this soft palate and the pharyngeal wall. So whenever a patient wants to make sound, there's air escape from the mouth into the nose. So the speech is hypernasal for this patient. So that explains the velopharyngeal mechanism. And it's actually important. Once this is not there, patient cannot be corrected. The speech of patient will still be hypernasal. So in conclusion, the anatomy of the lip, the palate, and the pharyngeal apparatus are important for speech production, and the adequate restoration of the cleft palate of patient's normal alignment and anatomy is important for obtaining optimal results with speech therapy. Thank you very much. I want questions and comments.
Thank you very much, Dr. Adamson Olawale, for that beautiful lecture on anatomy and physiology of Velopharyngeal Apparatus. We appreciate it very much. And we have some questions already waiting for you, at least about 3 of them. I'm going to read them out, and you probably may have to answer these 3 first.
Sorry, please, can I speak more? Let me hear.
So the first question here is, how soon can speech therapy commence after surgery? That's the first question. You know.
Sorry, please, I didn't get that, please.
Pardon?
I didn't get that. Can you say it again?
Okay, I said the first question I have here. Okay, let me start from the rear. Is it possible for some complications to occur years after the cleft palate surgery has been done successfully?
Oh, yes. It is possible for complications to occur. Usually, when some technique of cleft repair, there can be something called contraction. After repairing the soft palate, the muscles can contract, that is, shrink in size. When that occurs, the patient may have a velopharyngeal insufficiency later. So it's possible for there to be a complication, to have a VPI after a cleft palate surgery. Thank you.
Okay, thank you very much. Another question here is, how soon can we commence speech therapy after the surgery? How soon? 2 weeks or immediately? Or we should allow some
what I got.
Right?
Okay, how soon can we commence speech therapy? Well, usually, we wait till the patient is about 3 years old, because that's when the patient can cooperate with instructions. And also, if it's an adult patient, we usually wait for the soft palate to heal. Let's say about 3 weeks or more after surgery to commence speech therapy.
Okay, thank you very much. Another question, please, is it possible for somebody who has cleft lips or cleft palate after surgery, for that fellow with the help of the speech therapy?
So can I get that again?
Hello?
Can you say it again? I didn't get that, please.
Yeah, the question here, I'm reading it to you. It's also there. It's posted over there.
Huh?
So let me read it to you.
Okay.
The question is, after somebody has undergone the surgery and also has also undergone the speech therapy, for surgery speech therapy, can that fellow be able to develop speech communication and speech fluency as
Okay.
good?
Yes.
You've
The
seen the
person
question.
yes, the person can develop full speech. Can that person develop full speech communication? That's the question, right?
Yeah.
Yes. We've actually had even about 5 patients of ours that we saw that recovered fully, that their speech was normal after speech therapy. So it's very possible for a patient after surgery and proper speech therapy, they can get full speech development and go back to normal. We've actually about 5 patients that have done that and have gone back to normal, and you can't even know from their speech that they had the cleft palate before.
Okay. Thank you very much. Please, there is another question here.
Okay.
Does the quality of lip repair affect the quality of speech produced?
Okay, most times, the lip doesn't really affect the speech, only in bilateral cleft patients. So even most times for lip repair, I can say we get away with it. It doesn't, I'm not seeing it affect speech, but if the repair is so bad such that the lip is
Hello,
very
Doctor.
deficient. Hello?
Please, we have some problems here. Can you please say it again?
What do you say, please?
Yeah, we had a little problem hearing from your end. So I'm saying, can you please repeat your answer again so that everybody
Okay, okay. Can you hear me now?
Yes, yes. Now.
Yes. I said most times people with lip defects don't have speech problems. Okay? But most times people with surgery, most of them recover fully. But if the surgery is such that is very bad, especially in patients with bilateral cleft lip, there could be a minor speech defect, especially in some certain sounds, like the pa, the ba, and the va, the f and the v's. Those are the specific ones mostly that could have problems with the lip if it's not properly repaired. Thank you.
Thank you very much. Please, are you able to hear from me? Are you able to hear me well?
I can hear you.
Oh, okay. Yeah, this question is not posted, but it's just coming fresh, from me. And the question is, how can we foster collaboration, the speech therapists and surgeons?
Sorry, again, can you go again, please? Can you go again, please?
I'm asking, the possibility of the professionals from the surgery side, as well as professionals from speech therapy side, forging a stronger collaboration, advocacy as per the speech therapy for individuals who have cleft lips or cleft palate. The issue, of course, is that there are so many things to be done. Like you mentioned, there are categories of individuals, the children as well as adults. All of them have some social implications. Parents not willing to bring out their children who have clefts, adults who are not also willing to come out, for people to see their problems. Well, at times, then individuals also need to take the count of surgery. But then you still find that after surgery, some of them are reluctant to go for speech therapy. So the possible effort that we can pull together, to make sure that we reach one of those individuals, and those who also need to come for speech therapy, we come for speech therapy after surgery.
Okay, thank you. I do get it. But what we usually do in our center is usually we make the parents interact. You understand? Like the ones that have had surgery, they will interact with those that have had speech therapy, and they will see the effect of the speech therapy on those babies. We also encourage those that are fully recovered from the speech defects to interact with them. Once they see that it's possible for their children or for their ward to have proper speech back to normal, many times they're encouraged, they're motivated to come for speech therapy. So we do a modeling form. That means we use our success patients to motivate the other patients about speech therapy. Thank you. Do you get that?
Okay.
Did you get that?
Okay. Yeah. Thank you very much. I think you answered the question. Maybe subsequently we can, still talk more. My emphasis is the speech therapists and also surgeons, forming a stronger collaboration, or let me put it, advocacy on getting more individuals to come for surgery and also getting more individuals to go for speech therapy. Yeah, you find some of these individuals after they have succeeded in, undertaking the surgery, they don't even think there is need for them to go for speech therapy. And, it's just like a job half done. Breaching the illusion created by clefts is one issue. Having good speech, another thing, like you mentioned, the social, the social cultural aspect of it. If somebody is still not being able to speak very well, he's going to have some social challenges, cultural challenges, psychological challenges, and so on. Hello?
Yes, I did hear you. I do, but advocacy, yes, it's a big issue. Can you hear me?
Yes, I can hear you.
Okay, advocacy is a big issue. What I think we can do is if we providers collaborate together, that means we, like some patients, because of distance, may not want to come to where they went for the surgery. But if I have a collaborator somewhere close by, that's easier for them to go there. It's easier for them to go there. So if we speech providers collaborate together, the aspect of distance and their reluctance to go for speech therapy will be cut off. And also, we also need to educate our patients, the old patients and the new ones, about the importance. It has to be a continuous advocacy. If for those that started, sometimes they get let me say, they get depressed about it because they don't see an immediate improvement. We have to keep encouraging them. We have to keep motivating them. So the onus is on us to keep encouraging and educating our patients. And also, I believe more in the speech collaboration together, because some patients come from far for surgery. But if I have a speech therapist that is closer to the patient, it will be easier for the patient to go for that speech therapy than to come to my center for speech therapy because it's a repeated process. So I think two things we have to look at is collaboration between speech therapists, and also we have to have a way of continuous motivation and education of our patients on speech therapy.
Thank you very much once again, Dr. Adamson Olawale, for that beautiful lecture. There are so many recommendations for you already posted here. A wonderfully developed and wonderfully delivered lecture.
Thank you very much.
Quite educative lecture. So we appreciate you very much. I think the way you presented your lecture is quite very explicit that people don't need to ask many questions rather. So we appreciate you very much, and we
Thank you very much.
We are very grateful for that lecture, and we still hope to have more of you in the near future. Ladies and gentlemen, we have concluded the lecture, but then there is a bit of information for us to have. Number one is that we are quite very happy that this virtual lecture is taking place in the month of May. This is a wonderful coincidence because May is the international month for speech and hearing all over the world. So I think the lecture is part of how SPAAN and the SMILE Train are celebrating this year 2020 International Month of Speech and Hearing, though it's happening during the pandemic. But then it's also, like I've mentioned, that this lecture is coming up, at this particular time. So I like to congratulate all of us, and I also like to say happy speech and hearing month, to all of us. And we also like to emphasize that after this series of lecture, this series of virtual lecture, there would definitely be a class training that will involve the SPAAN and the SMILE Train, organizations working together. We have a wonderful lecturer who is based at New York, Dr. Kate Crowley, who normally comes to Africa and the rest part of the world, to deliver a lecture, 5-day lecture or 5-day training on cleft speech therapy. And there is a process we must undergo before we can get qualified for participating in that training. And one of the things is that we have to write certain examinations, and we must also score, certain good pass marks before we can be selected to participate in that program. Now, the information as to what we are going to do or when we are going to write the exam will be supplied, later, especially to members of SPAAN. So please, I want to encourage all of us to be on lookout for that. Once again, I'd like to thank every one of us from West Africa, East Africa, Europe, and the rest part of the world for participating in today's Cleft virtual lecture. I'd like to remind you that by grace of God, we are also going to have another lecture next week, Wednesday, same time, and also at same time. So we advise that in this period of pandemic, please stay safe as much as we can. Let's try to avoid the COVID-19. Once again, good morning. God bless you.